Welcome to the Low Carb Conferences podcast. I'm your host, Dr. Jeff Gerber. And today our special guest is Dorian Greenow, the founder of Keto-Mojo, who will once again be exhibiting at our event in February. He and his wife, Gemma Coaches, along with their team, have always been huge supporters of our events, and we're big fans of them as well. And it dates way back early to the beginnings of their company. So how's it going today, Dorian?
It's going absolutely fantastic. I'm super honored to be here, and more important, looking forward to your conference in February. It's here. Are we already over 1,000 people or something like that? It's going to be fantastic.
Yeah, well, we have room for 1,000. We're probably going to end up at 500, but 500, 1,000, it's going to be a fantastic event. And especially since Keto-Mojo will be there.
Thank you. Yeah, we're looking forward to meeting everybody and testing. I love going to low carb events because there's so many people that are in nutritional ketosis. It's great. Sometimes when we go to other medical events, not all the practitioners live it to lead it, I can assure you. And some of them refuse to test because they know what their numbers would be like.
Well, we'll get into it a little bit, but it's great because you have such a fantastic sense of community and a great sense of humor, and just our conferences wouldn't be the same without you, Dorian.
Thank you. Thank you.
So, yeah, let's tell the audience a little bit more about you. Dorian was on a personal health journey back in 2015, suffering from poor health, overweight, and metabolic syndrome. He and his wife discovered the ketogenic lifestyle, and along with monitoring blood glucose and ketones, Dorian lost 47 pounds. He came off medications and was rejuvenated with a new outlook on life. He was, however, frustrated because blood keto testing was very expensive and solely controlled by the huge biotech industry that was not interested in supporting the low-carb and keto community. Dorian was determined to bring about change. With persistence and fortitude, Dorian launched Keto-Mojo back in 2017 and achieved his goal to reduce the cost of blood ketone testing by 75%, along with inexpensive glucose testing. The product has been cost-effective and widely available to the nutrition-minded community. The company and testing methods continue to evolve, adding more features while at a reduced cost to the consumer. Dorian and Gemma have a strong sense of community. They attend and participate in many events as exhibitors and also provide educational content through presentations. We truly appreciate their contributions. And so, Dorian, if you can provide us some more background and tell us about your professional and personal interests and the early days of Keto-Mojo and more about its evolution.
Yeah, I'd be honored to, and thank you for a lovely introduction. So keto testing back in 2015, it was about $4 or $5 a strip, and predominantly Abbott was dominating the marketplace at that side. And when you get that moment of keto clarity, where you're like, the fog lifts from you, and you're like, wow, you've got that joie de vivre. You feel like you're 24 again, and you can take on the world. And you think like, well, why is this strip so expensive? And you take it apart and you look at the costing on it, and you go, this shouldn't be $4. Why are we having to pay for that? And so I drew up a list of 100 different manufacturers across the globe. I cross-matched that to the federal regulations, the 510Ks. And the business plan was very simple. I was on the back of a cocktail napkin, test 3 times a day for less than the cost of a latte. And that was my goal. I thought that if we had a lower cost testing, then we could provide them a low cost map and compass to try and help guide people on their journey. Because whenever you're trying something new and going somewhere, you want to know you're going in the right direction. But what the beauty of testing is we see people test a lot to begin with as they learn the route, they learn the way. And then the need to test diminishes over time. Like, we don't need to use a GPS to get to work every day, do we? We know the way, we know the route, we know what foods will spike us and won't spike our glucose, and we know what will keep us in ketosis and not. I mean, I test every time I test now, and I'm always in ketosis because I've learned the way. I now more test for curiosity, like, all right, we went out to dinner, we had a wine on the menu. Did it have residual sugar in it? What did it affect me the next day? How well did we do? And that's kind of like, and if I do see that my ketones are lower, I just do a little bit of fasting through the morning. But I have a high degree of metabolic flexibility. So that was the goal. Goal 1 was lower that cost, and we reduced the pricing by 75%, sort of like overnight. Then we went on to our second generation meter, and we were able to reduce down another further 20% from there. So we're roughly sitting about 80 cents at retail for a testing strip. And from there, we then scaled. We're in 36 countries. We're across the whole of the European Union, and the United Kingdom, Norway, and through that area. And again, bringing down the cost of testing to those regions. So that was kind of like goal one, was lower the cost and use the wealth of America to subsidize going into other countries to also lower the cost over there. Two was to build into an app to it. We needed to have to connect that data so that it could work in a modern society. Instead of just being a dumb meter, it would actually be a smart meter. And then after that was to be able to connect on in to other platforms like Carb Manager, Chronometer, NutriSense, Heads Up Health, Life Omic. We also connect different modern EHR systems now that are used by hospitals like Epic, Serbo, Validic, and Athena. And so we built this online platform called MyMojo Health. And the purpose of the MyMojo Health is to put into the hands of independents the same kind of tools that we see large companies like Virta Health in San Francisco approaching and utilizing a continuous remote care model versus an episodic care model. And I think that's going to be the next fundamental change, is how practitioners work with patients to affect metabolic change, affect that metabolic behavior change.
Yeah, so I know before we started the recording, you want to get into the care model, and we'll do that. But I'd like to kind of back up a little bit and ask you some more questions about this. And we've known each other for quite some time, and I remember that we would have some conversations in the hallways before the company had started up, that you basically refinanced your home. This was just a dream and a vision, and you just went all in and had this vision. And I have to admit, it was really frustrating back then. As you know, the importance of testing ketones in our community, and it was very expensive. And honestly, we would approach the big pharma industries, and they could care less, because ketone testing was for diabetics out of control, and they had no clue, and still they have no clue, and they have no interest in addressing the aspect of prevention and care, as you're saying. Am I correct?
Yeah, I mean, that aspect of prevention and care. Look, if the population goes towards a low carb metabolic lifestyle, these large companies who are earning huge amounts of money are going to lose huge amounts of money. We, on average, see our customers for about 120 days. And that's how much they're really testing for, because they learn a lot in those first 30 to 60 days. And then after that, they don't need us anymore because they are healthy. And so our business model is based upon us trying to actually go out of business. Sadly, there are massive campaigns out there from the food industries as well, that I don't think that the chances of going out of business is going to be hard when you look at everywhere you look, that there's carbohydrates. And so there was no real incentive for those large big companies to actually reduce their price. And because it was only dominated by a couple of players, they were almost in cahoots, if you will, about, well, you're staying at here, I'll stay at here, and you like that. It shouldn't have taken a husband and wife team to have used their entire home equity line of credit. And then when we lost our house in the fires of 2017, we used all of our possession money. We put it all back into the company to grow it into those other countries. It shouldn't take a husband and wife team to do that. A Fortune 500 company could have done it in a nanosecond if they actually cared about the healthcare of people instead of the sick care. And in this society, in American society, sadly, it's all about payment on sick care and not actually about real outcomes and getting real health for the population.
So well said, Dorian. And that's why we're all in this space and we all coming at it from different directions. And, kudos to what you have achieved with your company. And, our goal, as you know, I'm a healthcare provider and I'm still working in what you would call the broken healthcare system, but I'm helping my patients navigate through the landmines, as I like to say, and to address prevention and wellness rather than sick care. And so we will keep forging forward. But the other thing you mentioned is about, systems integration. And that leads me to the question of what is the authority that has to, approve devices? I know that you can go out on your own and get glucose and ketone devices. You need a prescription from a healthcare professional in the US to have insurance pay for it. But is there FDA regulation? What kind of regulation do you have to seek approval for?
Yeah, so for any device that has glucose on it, it's characterized as a class 2 medical device and so that is FDA governed under what's known as a 510K, because somebody will bolus their insulin based on the data that they're seeing on their screen. And there is a risk with that if that data falls out of what's known as the consensus error grid. So in any meter that has glucose, it has FDA oversight, not only in the factory that it's manufactured, the certificate of analysis that comes with every batch of strips for the import of it, for the actual company itself. So we have to have we are FDA registered before it can actually go. But the beauty of a glucose and ketone meter is it can be purchased over the counter, OTC, so that somebody can go to your website, they can buy it, and we can ship it directly to their home. But the challenge that we will find is actually getting it covered by prescription. Because, yes, you can get a glucometer, and you can get one every 5 years for the meter. And yes, they will pay for a certain amount of strips depending on your prescription. But they do not yet cover ketone strips, which to me, our goal, hopefully one day, is we'll be able to get the meter and covered under a prescription, and then hopefully be able to get ketones. But there's going to be a longer road to get there, because we have to prove to each insurance company the validity of testing for ketones, that you will have good glucose control. Now, I've got about 5.6 million ketone measurements and about a little bit more glucose measurements than that. And I know my average blood glucose is 101 across all of those measurements that you can see. There's average is 101, which I think is absolutely fantastic in a population. So what we have to do is be able to prove, to say, hey, if you are in nutritional ketosis, you will have good glucose control. And if you have good glucose control, you will have good outcomes. It's as simple as that, and as elegant, really. But it'll be a long road for us to get there, I think.
Yeah, I agree. I agree. But fortunately, ketone testing you've made cost effective, so the individual can pay out of pocket. Regarding the glucose testing,
I'd just love to address that with you, Dr. Gerber. I mean, I've seen people post up that they were spending $1,000 a month on medications. And a simple device change, along with some good advice, paired with your normal food that you would eat, but changing the type of food that you eat. I think that's an extremely cost-effective method of change. I think Virta Health actually showed that even using the Virta model and paying for Virta, it still saved a payer, an insurance company, like $9,600, I think it was over a 2-year period per person. That's astounding amount of savings that could be made when 10% of America's population, 30 million people, have type 2 diabetes. If you can save $10,000 over 30 million people, whoa.
Yeah. So people don't appreciate, they think that the cost of hospitalization is where the healthcare dollars go, but actually medication is huge before you get to the hospital. And so, when you do the math, it makes sense to do preventive testing, such as ketones, like you mentioned. It's a no-brainer. It's just, the healthcare industry doesn't get it. But my next question was, does does the insurance industry recognize Keto-Mojo as a glucose device that they would
Yes.
cover?
They recognize we are because we have the 510(k), it is recognized, but we have not yet been able to get an insurance company the process and for them to, so that a doctor could write a prescription and it could be provided. We're working toward it right now. We have got our HCPCS codes. I had to learn about HCPCS codes. I mean, look, I wasn't even in the health industry before this. So I was in the wine industry. So you have to learn a whole new thing. And somebody goes, well, what's your HCPCS code? And I'm like, okay, it's another organization that you have to be registered before you can get your HCPCS, which can then get you to the next part that's in there. So yes, you can certainly, right now, any doctor can actually use CPT codes when they're reviewing the data and looking at that or unboxing our product. A doctor can actually CPT code for that. So there's one financial driver for the practitioner in that respect. And the other part for us is to finally be able to crack that. Let your insurance company cover you for that once you, but it'll only happen if you have a type 2 diabetes diagnosis or perhaps pre-diabetes, which will be our challenge for other disease states to be covered.
Sure. Well, my point is just baby steps to work your way into the system. And so they approve the device for glucose testing. And then you say, hey, we've got ketone measurements and, maybe we can work our way into that as well. And brings me to the next point is that, not only to work your way in, but then to demonstrate that you have a device that's accurate, provides reproducible information. And I've kind of queried you on that over the years about the evolution of the device and how it's gotten better and less expensive. Maybe you can comment.
Yeah, I mean, so when we went to the second generation, we learned quite a few different lessons on the other one. And when we looked at it, it was like, how can we make this better? And one of the challenges that we had on the first generation was fill errors, the amount of blood necessary to pull on in and the speed that the blood went into the strip. So we actually changed the aperture, if you will, of that capillary tube that sucks up the blood through capillary action. So it came up in a lot quicker and faster. We went from a 4 electrodes to an 8 electrode. So that we could be better on humidity, the background hematocrit that is in there, temperature and altitude are coming into place. We're also adding those things. We don't show them on the display because the FDA won't allow us to do that. You can only show one thing on the display, which is either the glucose measurement or either the ketone measurement, and it has to be displayed in the same format, like America is milligrams per deciliter, but in Europe, we have to be in millimole in certain countries and other ones is there. So we changed the aperture. We added a light for low light pieces. We individually wrapped the strips so that, because on the old vials, you pop the top of a vial, all of those strips start aging out and they only have 6 months. So we wanted to have a safer product. And also by individually wrapping it, we could in America go to glucose oxidase dehydrogenase as the enzyme, and that then allowed us for the heat that we get on the last mile in like the UPS truck or the United States Postal Service truck, that it wouldn't have an issue with that. We actually baked our product at 140 degrees for over 2 weeks. And then did the linearity and aging tests on it. And I actually sent it from my manufacturing place in Asia all the way over to Chile on a boat so we could get the binaural temperatures, then all the way back on a boat, then went and did the accelerating aging to see what it would be for over a 15 to 18 month period, and then tested the linearity on that to make sure that throughout the value chain there, that we had the quality of the product through it. So there's a lot that goes into the background of bringing a testing strip to market.
Yeah, this is probably more than I need to know, but these are some of the hurdles that the home industry testing has to overcome. It's not specific to your device.
Yes, that's correct. I mean, you've got to deal with the last mile, and you've also deal with the quality of maintaining the quality, because at the end of the day, that data is being used in a remote patient monitoring situation. And you've got to, if somebody is changing their insulin or their medications, that deprescription becomes really important. So you've got to know that the meter will always meet what's known as the consensus error grid, which is basically if you can imagine a grid of lines that shows how accurate your product will be, consistency, repeatability, and reliability, and which we always do conform. Actually, we conform better than the federal American standards because we follow the more strict European ISO 15197 standards.
Okay, so I don't know about the European standards, but one thing that's frustrating to me and others is that in the US, they're saying that the measurement is accurate within 25%.
20%.
How many?
20.
20%. It's still a huge number.
Mm-hmm. Yeah,
And
the European standard is 15%. So we 100% of the time meet the American standard, which is 20%. We 99% of the time, which is what is according to the ISO standard, hit that 15% standard. You're allowed one time to be out on that one. And we actually exceed the European standard up plus or minus about 10%, about 97% of the time. Getting within 5% gets a little bit harder because that is sort of like you get that in about 67 to 70% of the time within 5%. But let's be very clear, this is of what is benchmark to a venous blood draw. Now, venous blood is different to capillary blood. So there will always be that. And that venous blood draw is usually done on a bench test. And those bench tests are $20,000, $30,000 compared to a $50 home machine using 1/5 of a drop. We're not Theranos here. There's only so much you can do before you get into the realms of getting something hugely expensive or something that is fake like Theranos.
yeah, and so this is kind of standards for large populations, but what we found is for the individual, you can kind of titrate it for yourself, and
Precisely.
So once you start doing measurements, they're accurate for the individual, and you get a good sense of that. Is that correct?
That is correct. You get your baseline. It's important that for normally what we say for people is get your baseline in the morning about an hour after waking, so that roughly. My baseline is about sort of like 1995. That's kind of like where I tend to sit on my meter. If I'm a little bit more fasted or I've been a little bit cleaner on the night before on my wines, I'll be in that 85 to 90 mark. I personally then if I'm measuring after a meal, about 45 minutes, I try, my consideration of a low carb meal is I don't get more than a 30 milligram per deciliter spike. If I'm getting a spike 45 minutes post, I'm like, what was in there? Did the waiter actually lie to me about the sauce that was in that curry? Then I can kind of figure it out. But at the end of the day, if I'm in nutritional ketosis, even if it's just 0.5s, and normally I'm between a 1.1 and a 1.7 personally. I remember though, the bioindividuality becomes vitally important. Higher is not necessarily better for ketones, though it depends on the why of the individual as to why that they're testing. But that's kind of where I sit.
Okay. Yeah. Well, I just have to throw this out. So, have some individuals or myself just thinking, why should we go with this hokey, small little company, Keto-Mojo? We don't trust the results. We're just going to go to big pharma.
Well, that's you could say hokey, but I mean, hokey in 36 countries with having FDA certification, CE certification, MDSAP certification, ISO 15197 certification. That's been used in 30 different clinical trials right now, is the choice of meter for Virta Health in San Francisco. It's done by Drs. Volek and Finney. We aren't that hokey small company anymore. We started hokey, but we're growing up as we go through. And, one of the joys that Gemma and I have is now we have our own 501c3 non-profit public charity called the Ketogenic Foundation, which is between our business arm and obviously our philanthropic arm. We're able to help further some of these clinical trials that are being done, or help different organizations like the Society of Metabolic Health Practitioners or the Keto Live group, non-profit that is in the EU. But for us, as we look, we want to give a feedback loop. We all stand on the shoulders of those scientists and clinicians and researchers that have toiled away in labs to give the data set to prove the efficacy. I saw Dominic D'Agostino speaking quite recently, and the amount of research that's being done, over 640 papers were published in 2022, and about 620 were published in 2021. And like, this is a huge amount of work that is now being done in this arena. And it's very exciting to be part of that and be able to support it.
Great, Dorian. Well, you can slap me upside the head for asking the question, but I just wanted you to state again to the audience how legitimate the company is and the things that you're doing. So thank you for that.
No, thank you for that one.
And so next topic is, I'd like to talk about some of the other testing that's out there, and specifically breath ketones and urine ketones, and where that all fits in with your product.
Yeah, I mean, obviously you've got three types of ketones. You've got acetone, acetoacetate, and beta hydroxybutyrate. And so there are different methods of potentially testing for those. So if you look at urinalysis, that measures acetoacetate that is potentially spilled within the urine. And most people don't actually know, we actually have the #1 selling urinalysis strip in America on Amazon. And on that, you can scan it and you can have a 104-page guide that gives you a how-to, but it also tells you a little bit of what are the drawbacks of trying to measure spilled acetoacetate in your urine, because you can get a false negative because your body won't spill it out, acetoacetate. Acetoacetate represents maybe about 20%, 28% of the energy in the body. It's very volatile, easily shunted into beta hydroxybutyrate, when beta hydroxybutyrate is very stable. It is the gold standard of testing because it's been used in all the clinical trials, because it can, like we said before, correlate back to a benchmark analyzer and has an ISO standard to it. So urinalysis, very cheap, very affordable, but it is going to give you a false negative. And then so it's unreliable in its methodology in that respect. And, urinalysis, what if you wanted to try to do this on a child that is having seizures, a baby for pediatric epilepsy? Blood then becomes a better solution because you can use the sole of the feet of the individual. Acetone, I think acetone holds a huge degree of promise, massive, because imagine that acetone, breath, non-invasive, how fantastic would that be? But the current sensor science that is used is called a MOX sensor, and that's a metal oxide. And the metal oxide, think of it kind of like a sieve in your sink. And as the acetone and other bits that are on your breath are going over it, it can get clogged. But so it does that both passively and actively. And as it starts to get clogged, it becomes unreliable. And so they try and put it through a burn cycle. So think like your barbecue, and they try and heat it up, but then it coats on to that sieve piece. And so you can end up quite quickly of having an expensive paperweight that will no longer correlate back to what's really happening in the breath. And so they tend to be a little bit unreliable. And I've looked very intently at breath. I was like, obviously I've got a urinalysis and I've got the gold standard, which is beta hydroxybutyrate. And we know that we've got to have somebody who's got to have a bit of skin in the game on that one there to prick their finger, though it's actually painless if you're doing it in the right way. But breath to me was a lot of hope. But as we looked at the underpinning of the science, not one of the current breathalyzers on the market actually correlate back to a mass spectrometer or a gas chromatograph. Now, as a scientist, and as a doctor, you want to know with a bit of certainty, as we discussed before, that the device that is measuring in the home will correlate back to within a certain degree of error with a benchmark test. And that's the challenge with all of those. And they get false positives. So if you've got a sugar alcohol in let's say a lozenge or in a food or in a cookie, alcohol itself will be a problem. Toothpaste can be a problem. A menthol tea can be a problem. Because it cannot tell the difference between acetone, methane, sugar alcohols, and alcohols. All the molecules are at the same size. So you have to be able to find a sensor suite that is specific to that. But I think maybe one day there'll be the science that will come out, but it won't be based on a MOX sensor that we currently see.
Oh, that's an interesting discussion. Now, I had heard the argument that the blood ketone, the BHB, is more of a buffer measurement, whereas the breath ketone is telling you the free ketones, what's going on at the current moment. What are your comments about that?
Well, it's sort of like more of an exhaust. Remember, this is acetone being exhausted out on the breath, and you've got to have a degree of accuracy on that one there. So if you look at the science that was done on acetone with the mass spec, nutritional ketosis starts at 5 parts per million. So you really need to have an accuracy of 1 part per million at 5 parts to be plus or minus 20%. Anything more than that, you're now at 30, you're now a third off, or even 50% of the way off. So you've got to have that accuracy at 5 parts. So yes, the science that was done on acetone with a mass spec or gas chromatograph, which are $20,000, $30,000 machines, are fairly good. But in a home test, they are not, because they don't have that kind of degree of accuracy. I would be very interested, we've been toying around with the idea is, can we actually do an acetoacetate blood measurement? I think that would be quite interesting to see that, whether or not it has a great application and use for the user. It might be more better for the scientist. But obviously, when you start going into those more esoteric areas, it becomes harder on a cost benefit.
Yeah, so breath acetone has potential, but it has a long way to go. It's not up to standard in terms of blood BHB measurement.
Yeah, exactly. Because it doesn't correlate back to any benchmark test, and you need to have that security on it. And yeah, maybe one day I'll bring out a breathalyzer. I've certainly looked at it hard, and we continue to look at new science that's coming on out and new methodologies, because I think it would be fantastic. Imagine having a non-invasive method. That would be brilliant.
Yeah, brilliant. I'd love to, so some of the other technologies, and to talk about the future and heading in that direction. So the other technology is continuous glucose monitoring, and maybe even continuous ketone monitoring. But, CGMs are out there presently. And, my thought is this should be the next direction for Keto-Mojo.
Absolutely. I think there's a great benefit to CGMs. I think there could be an even greater benefit to a CKM, which is a continuous ketone meter. Abbott did announce at CES, not this year, but the year before, that they had a Lingo product that would come out with new analytes. And I know of Dr. James McCarter, who heads up the new analyte division at Abbott. But let's take a look at glucose. Glucose, Abbott are charging what, $75 for a 14-day sensor suite. Dexcom is even more expensive. Do you honestly think that they're going to bring that price down anytime soon? No, absolutely not. They never brought the price down for ketone measurements when they had the chance. So it's going to be an expensive proposition, because the glucose enzyme is a lot cheaper than the ketone enzyme. The ketone enzyme is about 1,000 times more expensive than glucose. So there's usually 2 different types that they use: glucose oxidase dehydrogenase, GOD, or there's GDH, FAD. Do not ask me to say that GDH, FAD word, because I'm going to flub it up completely. It's so long and complicated. But that's how it is measured, and it's much cheaper than the ketone enzyme. And therein lies the challenge. I think we'll see these devices out, but they will be very expensive, about that $75 mark. There's no incentive right now for any manufacturer that I know of to bring down that cost, because they're all looking at Abbott and they all want to make this huge amount of money out of it. And so I think if you look at the premium, if you look at the cost that, say, using a CKM for a year might cost you $900 to $1,200. Testing once a day might cost you $203 on utilizing a finger stick. But realize we only see people for about 120 days. So we might see how an approach is done. For a disease state, it might be they want to go CGM, CKM to begin with for a period of time, then move off of that and then do finger stick testing. We'll see doctors and clinicians choose a different way. I think for the science on it, CKMs and CGMs are absolutely fantastic. I just wish that these large pharma companies weren't as greedy as they are.
Well, just to mention Abbott, somewhat fortunate, they've made their Freestyle Libre device within reach, so people can pay out of pocket, although, as you mentioned, it is somewhat expensive. And we've seen them go through different generations, and it seems to be getting better and better each day. I have a funny story. So we very much wanted Abbott to come to the conference this year. And we have reps, and they're so kind to us. They bring us tons of free samples. And our patients just, they love it because, hey, here, I can give them a month or 2 months of samples, and you just connect it up to your now it used to be near field technology. Now the Freestyle Libre 3 is completely Bluetooth. So you hook it up to your phone. You don't even need a reading device. It's your phone is the reader. And the patients are having a field day with it. And so we even spoke with the regional manager and said, look, the Freestyle Libre 3 just came out. We need you at our conference. The attendees of the conference will just eat this stuff up. And he tried to push through his channels and push through his channels. And the answer was, Jeff, we cannot come to your conference. And the reason we can't come to the conference is that we can't market the device to non-diabetics. We can't market to pre-diabetics, to healthy individuals. We can only market to, diabetics. And, he says, look, Jeff, I'm just as frustrated as you are. I see the potential in terms of prevention, but, at the end of the day, Big Brother says no. How frustrating is that?
It is, but it's also that they don't want to. And that's the point. They have chosen that they want to stay into that one lane because that means they can get the insurance money. And let's be very clear, when people go, oh, I can get it free on my insurance. It's not free on your insurance. Your insurance costs premiums. Why do you think your premiums in America are so expensive? Yeah. It's because of they're getting all of that money, and there's no incentive to bring it down because there's no real competition. Dexcom is happy at their price point. Abbott is happy at their price point, and they're going to keep jamming for that as long as. And also, if you look, measuring for glucose, you're measuring for an excursion. The only thing that you measure with glucose is how well your pancreas is at secreting insulin to manage to the foods that you've already done. Well, how about giving your pancreas a break, being ketones? Because ketones test for the right path, not the wrong path. If you are in ketosis, you will have good glucose control, period. Now, this is why Virta chose our meter, and Dr. James McCarter was actually was on the board with Virta. They knew of the new analytes. They knew what a CGM can do. But when you realize you measure ketones for adherence, then you know that that patient is taking their medication, which is the right foods. The right medication is the right foods. And they test for the glucose to deprescribe those pharmas, the SGLT2 inhibitors, and the other medications so that you do no harm. And that's the beauty of that system and why you do 2-in-1. It's deep prescription because it happens very quickly, and adherence. And you do that in your remote patient monitoring ways. So if somebody does fall off the wagon, you don't keep driving the wagon away for the next 28 days. You pick them up at the moment they fall off and find out why they fell off the wagon and fix that behavior change.
Yeah. Well, I think it's great that Abbott announced that they're working on the continuous ketone monitor. You and I were probably privy. We had spoken to Jim McCarter ahead of time that was what he was developing. But we're going to be stuck in the same loophole that if they do develop a product, it's again going to be something through the insurance industry and not necessarily something that can be used for prevention. And so that's why I throw the question out to you that a company such as yours needs to develop these continuous devices further so they can be cost effective and available to our community.
We've certainly looked at it. I can say that we've certainly looked very hard at it. And whatever company does that needs to have strong shoulders because of the patents that both Dexcom and Abbott have, and the patent lawyers that they also have, and the patent moats that they create to protect themselves in that way. And then any independent that comes out is going to have a flurry probably of litigation that's going to have to deal with it. in that respect. And that'll be a challenge for an independent company to do. Yeah, you got to have good lawyers on that one.
Wow. Yeah, it's interesting.
Welcome to America.
Yeah. Okay. Yeah, big corporations. That's what it's all about. So look, let's finish up with you wanted to talk about what the care model is, and then the future for the company.
Yeah, I mean, for us, we looked intently at just testing is one thing, but it's what you do with that data, or how that your coach actually works with that data. And I always had the pleasure of speaking with, being at the 7th annual symposium for ketogenic therapies for neurological disorders. That was in Brighton just over a year and a bit ago, last October, where Sarah Hallberg last spoke at. Dr. Hallberg. And she spoke at that one about what they called the continuous remote care model. This is kind of like how the VERT model works, which I'm showing up here. You have the tracking, you obviously have the patient in the center who's tracking their information, and it's going to an app. But that app then goes off to the cloud, where a team, a pod of, if you will, a team of be a registered dietitian, nutritionist, a health coach, or a physician oversight, can work with a whole patient population in real time. So what needs to happen with that is, if you think about behavioral change, if you could see, say we're working with 100 or 200 people, all right, you have a patient population of 100, 200 that has a small pod of clinicians that's working with them, and they can ask conversations in real time. And if you say, I want to see everybody's blood glucose this morning and blood ketones. Now, you can also tag that person and say, hey, does this person have medications? Because the first thing we want to do is look at the person on medications. We want to see their blood glucose. We don't want to have hypoglycemia, do no harm. Let's take a look. Do we need to be prescribed that individual? Yes, we do. We can click and say, hey, we'd like you to have an appointment with our care team. Here it is. We would like to perhaps adjust your medications. So remotely, at that moment, you'll be able to intervene for safety. And the second thing you can do is, like, everybody who's got it and doing really well, because at the end of the day, it's fairly easy to get into nutritional ketosis. You should then send all of them a message saying, hey, look, we looked at your ketone measurements today, looking absolutely fantastic. Keep up the good work. We love what you're doing. Now you're giving that accountability to the individual. They go like, wow, my doctor's actually contacting me. My team is contacting me, and they actually care about me on an almost daily basis. But you also know that Big Brother a little bit is looking in. Your coaches, your doctors actually care about you, and they're looking in to make sure you do. And then the third thing is you can do is, like, you can look at the ones who were not in ketosis or fallen out. And you can say, hey, have a message with our coach. We'd like to see what happened there. We noticed you're not in ketosis. And then they do the Calendly link and they come on in. And then they ask that question. And then what you find out is that maybe that person said, hey, yeah, it was Friday night, we're at work, it's pizza night, and everybody was asking, oh, just have one slice, just have one slice. So I ate one slice and it ended up to 2 and it ended up to 3. And that's why I'm no longer in ketosis. Well, then you can give the coping strategy. And perhaps the coach has said, you know what, next time I want you to have 4 slices of pizza, but scrape the toppings off and throw that garbage in the garbage and enjoy those wonderful toppings that is on there of the cheese and the pepperoni and the rest of it. And you can still enjoy it, because what that person didn't have was the coping strategy for behavioral change. And by doing that, you can now actually triage your patient population in real time and devote the efforts of that clinician or that doctor or that health coach team to those that need it, whilst giving affirmation to the others. So this was the model, and this is how Virta achieved 74% compliance versus like the classic episodic method of care, which we did a study on, where you might only get between 38 to 56%. So it was massive more using this type of model. So I think when you start combining different tools, you get a force multiplier. You need to have the right resources for people, you need to have the right data set, and you need to act on that in real time to affect it. So we built in our MyMojo Health platform this ability based upon Dr. Hallberg's paper. And then we started giving it to clinicians. We have about 60,000 monthly users. And what was really fascinating was Dr. Boz did a new twist on it. and she utilized positive peer pressure. So she got her group, 200 people, and then using lay coaches with her oversight and utilizing our system, put them through a learning course. But everybody had to agree, like you would go in a group, to be able to share the data without that. So you're having this positive peer pressure for behavioral change. And it was fascinating what she achieved in her 21-day program. So now what we are loving to see is how clinicians are taking what we've designed, giving us feedback, and from what we get the feedback from the clinicians, we then provide the tool back to them so that you can scale. You can scale massively metabolic change so that you can have a healthy population. And I personally think that this is going to be the more interesting way that we're going to see metabolic change happen, not only in America, but in other countries.
Oh, that's great, Dorian. We actually reached out to Dr. Boz to get her to come to one of our conferences. Unfortunately, not this year, but
she is a force of nature. I can tell you, I'm very proud to have partnered with her, and she came back willingly with the feedback of what she was doing, and we adjusted our platform for her needs. And that's what we like to listen to the doctors and clinicians and say, what are you doing? How is this working for you? What do we need to change on that platform? Because that MyMojo Health platform we give away for free. We invested over $2.5 million in creating this amazing platform to have this so that any independent clinician can have the same tools that Virta Health have. Virta Health has spent 300 million plus, I think, on their Series D funding and trying to create this thing. But we need to engage an army of independents and give them the same kind of tools so that they can be as successful, are probably even better than the Virta Health, because when you have an independent doctor and that one-to-one touch, that's very special.
Yeah, well, that's where I fit in. And I've always found it a challenge because we do, general medicine and we're still, working in the health insurance industry, and so many things are coming at us in so many directions. And then
the Boz model was unique in utilizing lay people that she'd already taught and trained, and then putting them into small teams of like 15 to 20 new people in with that one team, with a learning management system. So the course that they went through, everybody doing it all the time, and then the physician oversight to each one of those little small pods in that respect, and showing the data live and utilizing use cases and training for that positive peer pressure. And sort of like how you do group for alcohol addiction or the other kind of like things. And that's, so she was taking this new approach to it, which is really interesting to see how, because adherence is everything. 28% of people don't even take their medications. So how do you get a better adherence to that initial intervention, which is an intervention, so that you can give the tools to that individual so that they have discipline for life. And this is what the military do. This is why they put recruits during boot camp. We have to change our old methods, our old lifestyles, and not everybody can do it on their own like I did. There's different ways that you can give assistance and help within that.
If an individual purchases your device, do you offer remote care access to them without a provider?
So we have huge amounts of information on our website so that people can do a self-guided journey. All of it has been reviewed by either our own clinical educator, Jessica Ernst, RD, sits on our team, or it's been overseen by Dr. Nasha Winters. So we have how-to guides, we've got recipes, we've got meal planners, we have videos. We have, in fact, we've got over 200 hours of videos that is on our website of some of the leading researchers and doctors in that respect. So we give a huge amount of information for free for people to do their self journey. I haven't got into the way of coaching yet because I like to give that to you guys for recommending my product. I don't need competition for everybody.
Well, so many familiar names in the community. Nasha Winters, I think, is from Grand Junction, Colorado, and we're a big fan of hers. And that's great that you have her on.
The work that she's doing at the Metabolic Terrain Institute of Health is outstanding, and she's working towards creating the first metabolic hospital in the United States that's devoted to metabolic oncology with some leading researchers that is there. I'm very happy to be able to partner with her and their team across the globe, because I think as we see utilizing ketogenic diets as an adjunct to the standard of care for oncology can actually have some profound effects. We work with Cedars-Sinai Hospital for GBM. We're in a second clinical trial with them on that one.
Well, that's great, Dorian. Well, look, I think we really covered the future, but just to finish up, a brief comment about the future and anything we missed that you had to say?
For the future, I think there is going to be, first of all, some exciting products and methods of testing that will come out, especially, I think, in the near-term timeline horizon. I think the method of care is going to be profoundly changed. COVID has shown that with other doctors, with the change in some of the healthcare data rules, we're seeing a lot of new systems adjust and change. And it might actually be a country in the European Union or a smaller country, a single payer system that's going to first break the logjam, if you will. Because if we just look at the cost for a single payer system, the taxation burden on society, because society is so sick, needs to adjust. But if they can suddenly realize, we see Dr. Elwin talking about how in his practice, he saved over £65,000 in just medications in his practice. And if it got replicated throughout the NHS in England, they would have enough money to build a brand new hospital every year. So this is how, if we look at our insurance costs that we're paying and a single payer, metabolic health will save our society money. And if we look at regenerative agriculture, we can actually sequester carbon at the same time. But that's another little rabbit hole I could go down on that way. But I think that's the future that we will actually eventually see happening.
Great. And look, we know that you and Gemma love going to events and conferences, and really you're one of the, I would say, few companies that even throughout the events of the last couple of years have continued to travel, and now you still travel throughout the world promoting the message and your products. And I just have to ask, what is it that the two of you enjoy so much about travel?
Well, there's always the classic joy of travel, is meeting new people and enjoying fantastic new restaurants. And I love to eat out. Both of us enjoy food and wine. So we get that joy from it. But more important is if we're able to help support a conference, we're able to support the ideas, the interaction, and to be able to bring out new scientists so that scientists and clinicians can learn what's absolutely happening, and so that we can affect a greater degree of change. But it's only from people like us, and I would like to see more food companies and more that are in the ketogenic space. I see them, they're saying, oh, this is keto and that's keto, but where are they stood side, shoulder to shoulder to try and help people like yourselves who are trying to spread this message to other clinicians and researchers and doctors? And if we can get that buoyed up, the next thing is, how do we get into these societies and guilds across America to have them to listen? Because it's we got to get out of our echo chamber, and that's the challenge that we find is at the American Society of Bariatric Surgeons, why aren't they saying, hey, let's go keto first before we go to the knife? These are the questions that need to be asked when the success and the clinical studies need to get done. And that's kind of like what that fuels Gemma and I to affect that change. We don't have kids. What's my legacy? That I made a buck or I made a difference? And that's why we have our ketogenic foundation, is so we can try and support this and then lift the whole of the community up.
Oh, that's great, Dorian. And, we have the same challenge with our conference now in its 6th year, that we are trying to reach beyond the echo chamber, and maybe in the future rename the conference to Health and Nutrition, and not give it another name beyond that. But really appreciate your comments. And how can the audience find out more about you?
Yeah, just go to ketomojo.com, quick googly moogly on that one, and you will find us. There is huge amounts of information for free, so people can learn on their journey and find out what we're doing next. We also have an event there, so you can see which events that we're going to be at next throughout the country and the world. And we look forward to seeing you at Low Carb Denver. It's only just a few weeks away. It's so exciting.
Yeah, we're excited to have you, Dorian. And to our audience, we have such a great lineup of exhibitors, including Keto-Mojo, and it's just a pleasure and a gem to spend time with Gemma and Dorian. Our exhibitor list is quite a list because we're covering food, biohacking, testing, lifestyle. So it's going to be a bit different in terms of the exhibitors that we have. Peter Bowman is our expo manager, and he comes from a background in biohacking, and Dave Asprey. So that should be interesting. We have
fantastic. I mean, we do a couple of biohacking conferences. We did one in Helsinki and recently just one in Amsterdam. And the intersection there between metabolic health and biohacking is absolutely fantastic. And I love their curiosity. I love how they like to dive into the science. Yes, we can see some things that are potentially at the edge of woo-woo, but magic and woo-woo was before we actually understood the science behind it. But love doing those conferences too.
That's great. And we have a great lineup of speakers. And actually just this week, we found out that the talks were approved for educational credits for healthcare professionals. And as you know, the healthcare professionals, they do need their educational credits. So that's an impetus for them to come and visit with us, but it's also open to the general public. And if you want to support our conference, if you want to support nutrition science, please consider attending in person. There's still plenty of time to register. And there's also an online virtual option for those who can't attend. And we have this fantastic Whova app that just will bring everybody together. So look, that's all for now. Dorian, thanks for your time. And we look forward to seeing everybody at the event.
Thank you.